My name is Joshua Everhart, and I am the corresponding author for this technique guide. I will be narrating this video for our technique entitled Piriformis Tenotomy and Sciatic Neurolysis via a mini-open approach. We have no relevant financial or non-financial disclosures. Piriformis syndrome is one of several entities that can cause deep gluteal pain syndrome. Piriformis syndrome causes compressive neuropathy of the sciatic nerve at the level of the sciatic notch. Frequently, there are associated fibrovascular bands or adhesions between the piriformis and sciatic nerve as well. This is a representative MRI of a patient that had severe piriformis syndrome. As you can see here, as indicated by the blue arrow, the piriformis muscle significantly atrophied compared to the contralateral side. And I'm tracing out the piriformis here. T1 imaging is best for viewing the sciatic nerve, and you can clearly see the pathway of the sciatic nerve. This doesn't provide a definitive diagnosis for piriformis syndrome. This is based on clinical exam and can be supplemented by EMG or diagnostic injections, though exam is the most helpful in this situation. MRI is helpful for distinguishing relevant anatomy, in particular if there is an abnormal anatomic relationship between the piriformis and sciatic nerve. And we do occasionally see a bigastric piriformis muscle or other variants. This is my typical positioning for this surgery. So they're in lateral decubitus position. I mark out the greater trochanter. I try to position the incision fairly posterior or proximal on the greater trochanter. This gives me better access to the sciatic notch. And if you place this well, you can do a fairly small incision to complete the entire surgery safely. I dissect down to the IT fascia and split the iliotibialis fascia and glute max along with its fibers. You really don't need to do a whole lot of muscle splitting to get good exposure of the piriformis with appropriate placement of your retractors. Here you can see the piriformis tagged by traction stitch right here. There's often an overlying fat pad that you'll need to remove. That can be fairly vascular, so be careful when you're doing that. Once you have this exposed, you're ready to begin the actual tenotomy. In this slide, you can see the piriformis tendon after the tenotomy has been performed at the level of the greater trochanter. What I'm pointing out here is, despite me pulling fairly hard on this tag stitch, the piriformis is not moving very much because, as often is the case in patients with piriformis syndrome, there's significant adhesions between the tendon and the underlying capsular tissue or to the nerve or other surrounding tissues. So this needs to be freed up. This is the next step in the surgery. So this is the final step. Here you're going to want to remove all remaining adhesions and fibrovascular bands in and around the piriformis and sciatic nerve. This has been done, so on both of these images here, I can fully mobilize the tendon up out to the level of the skin or past it. I like to use electrocautery that's bipolar when removing these fibrovascular bands. Be sure to feel into the sciatic notch itself and palpate and make sure there isn't anything else that is laying over top of the sciatic nerve that needs to be released. You could have an accessory slip that you weren't aware of or a hidden fibrovascular band. Do make sure that you have adequate hemostasis once the procedure is complete, and then do a standard layer closure. Thank you very much.